Why do I need B hex rings and iris hooks and pupil expanders when I have a very efficient technique to show you how to go in these small pupil cases and softer cataracts? Hi, this is Dr. Semanchal Goel, and today I'll put forth a technique which you can keep in your armamentarium and make good use of it when the cataracts are softer on the softer side and the pupils are small. Coming back to the case, I have made two side ports which are slightly anterior to the limbus because of the fear of iris prolapse. Always make side ports anterior to the limbus in these small pupil cases. We'll go about doing the usual steps, and as the case progresses, you're going to see some novel steps which you must observe carefully and try to mimic them the next time you encounter a small pupil case. You're not going to need those expensive B-hex rings or iris hooks and cause injury to the iris in the post-operative time. It increases the inflammation, it increases the recovery of the patient, and so we'll not use any phenokin plus, any adrenaline, which usually cause corneal endothelial damage as well. We won't be using any of the devices as the cataract grade is around grade 2, grade 3. As you can see the glow passing through the lens, the cataract is relatively soft. The pupil is around 60 to 70% dilated, and I suspect that I will have a failed chop because the nucleus is too soft. So what do? The technique for me to go to in these cases is carousal technique. Mind you, 3 important steps that you have to do to make a successful carousal are a decently good sized rhexis, that is around 5 to 5.5 mm of rhexis. Step number 2, a good hydration causing one pole of the nucleus to pop out of the bag. Just notice it carefully, and hydrodissection wave done, pushing the nucleus to and pop. As you can see, I have prolapsed the left pole of the nucleus out of the bag, and the iris is holding it right now. I'll make it more pronounced for you all by pushing some visco beneath the pole of the nucleus and the bag. I'll put some visco to protect the central endothelium, and yes, just see. This is the step number 2, the most important step. It depends on the dominant hand. Your dominant hand, if it's right hand, then you have to prolapse the left pole of the nucleus and vice versa. And this is the most critical step, step 3. You put your dialer in a position that the nucleus cannot prolapse in the bag, and ask your OT assistant to switch the continuous mode, high vacuum, high flow, and put the pedal in the position 3, and just enjoy this cartwheel rotation of the nucleus, and in no time, within 15 to 20 seconds, the nucleus will be out. It's so fun to watch. If you want to see this brilliant, brisk, and gratifying movement of the nucleus, you don't have to chop this nucleus, it will come into the phacoprobe on its own. Small miniature choppings you can do, but beyond that, the nucleus, the hard part, the endonucleus, has gone in no time, spinning in an elliptical fashion, just like planets do. So yes, within 20 or odd seconds, the nucleus is out of the bag, and yes, we are done with the case. The nucleus has gone down, and just imagine the size of the nucleus. If you were chopping at this time, the case would have been difficult, posing a threat to the patient's posterior capsule. These patients, especially in the hands of newbie surgeons, can land up in PCRs, and these unexpected PCRs can eventually land up in lens drops. These cataracts are very hard and challenging for new surgeons because the chopper goes through and hits the posterior capsule in no time. You can employ this technique in diabetic cataracts as well, because the diabetic cataracts tend to be gooey, sticky, and they won't chop as well. Carousal or the cartwheel technique is a brilliant technique which decreases operative time and is known for its low inflammation in the post-operative time. So just we are on the simplest of the steps right now. We are just about to complete the I&A, and we'll be putting a monofocal IOL as this patient hails from an underprivileged background. We are operating this patient for free under the National Health Protection Mission. And yes, we see a beautiful outcome already. The nucleus has come down to 50%. I beg your pardon. The pupil has come down to 50% of its original size, and but we are done with the case. We are just taking the cortex out. It's always a good idea to just elevate that iris to see remnant cortical fibers if you may. And as I'm assured that there's no cortex left right now, I'll be hydroimplanting the IUL under irrigation. And yes, let's call it a day. Let's call it a case, and hope you like my videos. It would be really helpful for me if you guys just like, share, and subscribe. Just refer my channel to your friends and colleagues who are in the learning phase of their careers, and it would mean a lot to me. This is Dr. Simanchal Goyal signing off. Hope you have a great day ahead. Thanks.